with that, we're going to go ahead and go to our second article, which is the prognostic value of computer tomography classification system for intra-articular calcaneus fractures by Dr. Bernishko and et al.
There was the classic descriptions of calcaneus fractures were usually lumped into two basic groups: tongue variants and joint depression injuries. And there were classification schemes that were just based on that, really not on the fracture line. Then there was an attempt thinking that if you classify the number and the location of the fracture lines of the posterior facet, that had some prognostic outcome. And turns out that doesn't, because it turns out really what's more important is the fracture line location is directly attributable to how difficult the fracture is to reduce, not necessarily that it's going to do badly. In other words, a very medial fracture line of the posterior facet is more difficult to see well. And then a segmental injury to the posterior facet, it obviously matters on how well each section is reduced. And what became clear when we were looking at any of the classification schemes before, nobody really talked about they just talked about the joint. They didn't talk about the rest of the morphology of the heel. And essentially what we realized is that once you take into consideration all the fracture fragments, especially the anterior process, you realize that that's actually the crux of the reduction, is reducing the front, which is really distal to the critical angle of Gethsemia. In other words, just distal to the posterior facet, because that always gets driven up into the sinus tarsi, lateral to the talar head and neck. And unless you bring that anterolateral fragment or the anterior process down, depending on how comminuted it is, that is really the lighthouse to the subtalar joint. Because if it doesn't get brought down essentially inferiorly or planarly and back to where it should go, then the talus cannot articulate with the posterior facet properly, because literally, essentially, what you are accomplishing is what I was talking to you about today, is the subtalar joint gets seized. In other words, you cannot pronate the foot because the front of the talus has no place to go, because the anterior process is literally blocking its ability to move in the coronal plane, based on and we basically were trying to illustrate that where the fracture line does occur doesn't really matter. It's a matter of the most common problem is the anterior process, or the most difficult reconstruction is the anterior process. And so the articular reduction is part of the problem, but the main dilemma is the whole shape being restored. In other words, the length of the front, and then the tuberosity is kind of the last stage. You fix the front, then you fix the middle, which is the joint, and then you fix the tuberosity at the end. Whereas classically, everybody started from the middle. And the problem is the anterior process is the key to the whole fracture, which most people don't even nobody talks about the anterior process, really. Well, I think because the Sanders classification really only talks about the posterior facet, it doesn't talk about the relationship of how that fits with the rest of the morphology of the heel, meaning the tuberosity or the anterior process. And so, when you see the fracture classification, it doesn't distinguish between joint depression and tongue variants. All classification that I was using was Lichtenell's classification, because he wrote a paper about the number of fragments in the anterior process. I mean, I can send that to you, but we call it a Lichenell 1, 2, 3, or 4, because he was the one that actually was the only one that ever actually even talked about the anterior process in the 80s. Once you get the anterior process down, the cuboid follows that. And so essentially that indirectly has a direct bearing on the outcome of the fracture of the calcaneus, because that also is pivotal with respect to Chopard's joint. In other words, the the Simon line between the talar mandibular joint and calcaneus cuboid joint. If you bring the anterior process down where it should go, the lateral column of the foot is reestablished. And if you don't bring the anterior process down, almost by definition, what ends up happening is the cuboid follows that malalignment, and the foot essentially is starting to go flat. In other words, the lateral column is short by virtue of the anterior process being truncated, it's shortened. And so once you restore the length, which involves the fracture lines of the anterior process, and the more line. In other words, when you get shortening and then you overcome shortening, there will be many times cortical reads on the superior part of the anterior process that actually it's properly realigned, and you get an AP of the foot, or you can see the best way to understand it is if you look at a pre-op lateral of somebody that has an unfixed fracture, you can never see the middle facet, because middle facet is a medial structure and the lateral part of the anterior process is above it. And so it obliterates your ability to see the middle facet. When you bring the anterior process to length and inferior, you essentially bring it out to length and inferior, then all of a sudden you can look through the sinus tarsi and see the middle facet, which really essentially tells you that you are getting the lateral column down where it should be. I don't know, 20 years, we didn't really have good implants to manage a very comminuted anterior process. So we would reassemble the fracture fragments, and then because the anterior process was comminuted and we didn't have locked plates to hold the front down well, we would put the plate that we fixed the heel with was extended out onto the cuboid. So in other words, you would anchor, you'd be holding the anterior process down by virtue of being anchored properly to the cuboid, so that you restore that calcaneus cuboid architecture, but unfortunately spanning the joint. And you'd have one or two screws in the cuboid, and then 6 months later, to free up their calcaneus cuboid joint, you cut the plate off or take a screw out. And then as soon as, a lot of people say, well, the anterior process is too comminuted, you can't fix it. Well, this allowed us to get it realigned, but the problem is it does bind up the calcaneus cuboid joint. With the advent of lock platings, especially the newer lock plates, not necessarily the older ones. The older ones were pretty rudimentary, but the whole point was that you would be able to contain the anterior process position without having to go to the cuboid.